control methods that are out there, but essentially what we're looking at is the chemical or the hormonal control. So birth control tablets. Learning objectives discussed here. You can read those by yourself. So just some background. Nearly half of all pregnancies in the U.S. are unplanned. Okay, and that's different from unwanted. All right, just to be clear. These are unplanned, meaning unexpected. 95% of that is attributed to a lack of a consistent birth control method. And so whatever method they decide to use, most of this is attributed to inconsistencies within that particular method. Excuse me. It does cost a lot of money to raise a kid. I have 2.5, and if you go home for Christmas this year, or if you or Thanksgiving, make sure you tell your parents thank you. Current estimates, it takes over, I think that's even wrong. I think it's $400,000 to raise a kid to 18. So see mom and dad, give them a big hug and thank you. And of course, this represents decisions for the mother and possibly even the couple. Raise the child, adoption, abortion. So these are all current hot issue topics, both nationally and politically. And this information was gathered from the Guttmacher Institute, which can be found online. And so what are the options that exist in terms of birth control? Of course, abstinence would be probably the most efficient. Of course, there's the withdrawal method, known by its Latin term coitus interruptus. Especially if you've seen Big Bang Theory, you're familiar with the term coitus. It's Sheldon's favorite word, referring to sex. Then, of course, there's periodic abstinence or the rhythm method, and this is based on noticing changes in cervical mucosity as well as viscosity. Body temp, it's not really reliable because there are some variations from month to month. As we progress further down the list, we can look at barrier techniques. There are both male and female condoms. Of course, never use them together. Diaphragms, cervical caps and sponges. And then, of course, oral contraceptives, which we'll get into in a minute. So the 1950s, let's go back to the 1950s, an era of really cool cars with excessive amounts of chrome. And my favorite TV show, the 1950s, I Love Lucy. If you've ever seen this episode, this is the Vita Vegemenin. There's a little bit of alcohol in this vitamin formulation, and she's doing a commercial, and she gets drunk as she does retake after retake because she keeps screwing up the word Vita Vegemenin. So it's really funny. Of course, there's my midlife crisis car. I wasn't born in the 50s, but I truly appreciate them for the cool cars that they had. So the 50s brought us a kind of a cool history lesson. So in the 1950s, a feminist, an heiress, an endocrinologist, and a gynecologist walk into a bar. And it sounds like a joke, but it actually happened. And it wasn't really a bar, it was actually a cocktail party. They all met at a cocktail party, but close enough. And they agreed to make a safe version of birth control pill or tablet that has a steroid or a cholesterol background in its chemistry. And then, of course, these people were Margaret Sanger of Planned Parenthood, who would go on to found Planned Parenthood. Catherine McCormick of the McCormick family, large, wealthy family. Gregory Pincus, who was the endocrinologist, and John Rock was the gynecologist. And so they had found that looking at a natural source of estrogens and progesterones from this jicama, or this Mexican wild yam, which is kind of a cross between a fruit and a vegetable, that they can extract these cholesterol derivatives and basically make excuse me, estrogen and or progesterone. So there was a lot of chemistry that went involved, but I just want to remind you that cholesterol is really the background building block for all of the steroid-derived hormones. And of course, you can turn cholesterol into progesterone, going through this intermediary pregnenolone step, and you can convert cholesterol into some of these other intermediaries, and of course into testosterone and then estrogen. or estradiol. So they made the pill, and we got approval in the FDA in the late 1950s. But these were the indications, all right? So only for severe menstrual disorders, okay? Not for contraception. That was what these drugs were for. The number of severe menstrual disorders, quote unquote, jumped immediately. So a woman was actually using them for birth control, kind of off record. And things changed within less than 10 years. I mean, by 1960, the pill was approved for contraceptive use, and by 62, over 1 million women were prescribed this pill for contraceptive use. And so it's associated with tons of social controversies. Many exist still today that involve the church, particularly the Catholic Church, minority rights, things that revolve around the sexual liberation of women, and then this notion of side effects that basically kind of led to the mistrust of the pharmaceutical industry. And we'll touch on some of these topics as we go through this lecture. But it's really interesting how this all kind of played out, and from a historical perspective, kind of led us to where we are today in terms of some of these issues. So these drugs are hormone based, and they have a steroid backbone, which I said, and really the two that we're looking at are going to be chemicals that look very closely like estrogen, as well as progesterone or progestin, and they can be combined into one formulation. CHCs are sometimes called combined or combination hormonal contraceptives, and basically all we're doing is tricking the body into thinking the patient's already pregnant. And of course, if you're pregnant, you can't get more pregnant, so ovulation is prevented, of course, not fertilization. And when properly used, these drugs are over 99% effective, and the key word here is properly. So we go back to that negative feedback loop that exists from the hypothalamus. Excuse me. We go back to that negative feedback loop that exists from the hypothalamus and its effect on the pituitary as well as the ovaries. And of course, remember, the ovaries are the site of estradiol and progesterone secretion and production, and then that has a negative effect on the hypothalamus as well as the pituitary, depending on which hormone you're talking about. So I'm not going to go through this whole thing, but I just want to recall that essentially, you've got two phases. You've got a follicular phase where the follicle's undergoing development, and you've got a luteal phase, essentially where basically the decidua has been substantially increased. There's an increase in the progesterone levels, and then there's a different type of chemistry that's associated with the process of post-ovulatory events in terms of looking at the follicle. Kind of the dividing line is really kind of this LH surge by around day 13 to 15, usually 14. And that's really kind of the key distributing difference between the follicular and the luteal phase. So the mechanism of action of these drugs is really to kind of prevent ovulation as well as follicular development by reducing the release of these gonadotropins. And so that's kind of that negative feedback loop that we had talked about. A lot of these drug combinations that are included with the birth control tablets interfere with this LH surge. Okay, so if that LH surge by around week or day 14 doesn't occur, that's really going to have an alteration in terms of the endometrium's ability to kind of proliferate, and there's going to be really no good environment for implantation to occur. We also will see changes in cervical mucus. So if sperm is encountered during this crucial period, the environment is kind of inhospitable. So there's a couple of different side effects in terms, not side effects, mechanistic effects of how these oral contraceptive tablets work. Okay, and so we kind of go through step by step in the next three pink slides, so you can see this. And so here's a normal cycle and what happens at each portion compared to a cycle with the pill and what happens. And so you can kind of compare and contrast the differences. Some of the key features here, and I'll just really talk about the pill side. You can read the normal cycle on your own for comparison. Days 1 through 5, the estrogen in the pill suppresses enough of the production of FSH so that ovulation does not occur. Days 6 through 10, there's a pituitary gland decreased production of FSH, and so there's no dominant follicle that's recruited from the follicular environment. There's no increase in estrogen, and there's no increase in uterine lining or through a process called decidualization. Days 11 through 13, you see kind of low levels of progestin being signaled to the hypothalamus as well as the pituitary, and that also kind of prevents that LH surge. That was kind of the key dividing factor between the ovulatory phases, which are shown here, and the luteal phases, which will be on the next slide. So the luteal surge is avoided, so the luteal phase is severely restricted. Ovulation is inhibited as well. No ovum is going to be released. There's going to be no change in progestin levels. Really a lot of the mechanistic aspect occurs, between days 1 through 22. Days 23 to 25 are really placebo pills, at least in the birth control packet. They don't really contain hormone. Here you kind of allow some of that shedding that was built up with a little bit of the uterine lining. And so we can talk about the placebo tablets later. But this essentially is what happens during a normal cycle on a pill. Okay, and of course that's just reiterated here so that you can see the whole thing.